Welcome, Commissioner. I want to welcome commissioners and members of the public. This is another, perhaps our last remote-only commission meeting. I'm hopeful that by next month, we'll be able to transition back to at least hybrid. Given that this is a remote-only meeting, additional ground rules apply. I'll begin the meeting with a roll call of commissioners. During the meeting, I'll ask the people speaking identify themselves before doing so. And that way, the commissioners and members of the public will know who's speaking and have the same knowledge as if we were all together in room 100. We're using the Zoom platform today. All commissioners may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I do ask that commissioners and all others mute their lines and their computers when they are not speaking. For this meeting and at future remote-only meetings, we've posted documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them and absorb them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into or log on to the meeting by posting that information on the homepage of the website and on our various social media channels. I will now call the roll. Commissioner Akintade. Bim, I don't see you and don't hear you. Okay. Commissioner Bandari.
Yeah.
Yes. Commissioner Boyer.
Here.
Commissioner Boyle.
Here.
Welcome. Commissioner Brumbatt.
Here.
Commissioner Cheatham. Commissioner Cheatham. No. Commissioner Dorton, I see you.
Here.
Welcome. Commissioner Jensen. Not yet. Commissioner Metz, I think I saw you.
Yes, sir.
Commissioner O'Connor, we heard from. Commissioner O'Grady, I believe I saw you as well. Yep. And Commissioner Wang.
Here.
Excellent. Included in your packets are copies of the minutes from the January 20th, 2022 public meeting of the commission that took place by video conference. I will entertain a motion to approve the minutes of that commission meeting with the correction from Dr. O'Connor that he was present. Motion, Commissioner Dorton. We have a second.
Second.
Commissioner Boyle. All in favor?
Aye.
Aye.
Any opposed? Outstanding. All right. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Does the executive director have any updates for us?
Thank you, Dr. Pollack. We have two representatives from the nursing home industry today, and I know that they've stepped away from legislative work. So I'm going to be very, very brief and just talk about a couple administrative points that I want to emphasize to the commissioners. The financial filings required of all gubernatorial appointed board and commission members are due. They will get progressively more pointed if you don't complete them. It's an important matter under Maryland ethics law, so please do so. And I did want to give everyone a heads up. Dr. Pollack and I have not yet had a chance to meet with our new appointee. Her name is Carrie Hill from Southern Maryland. She will be joining us, I think in March, but we haven't talked to her directly, so we'll keep you informed. I'm very happy to let everyone know that she's going to be a member of the commission. And also, I know that there's been a little confusion about hearings. For those people for those commissioners that are going to go through appointment hearing, I'll be back in touch with you. I think right now, the only commissioner would be Commissioner Jensen, but I want to look through the list and make sure that although this is not something that we control, that everyone feels comfortable and knows when they should appear. If you're up for a reappointment, keep in mind that you don't have to appear. That's the important point. And I'll turn the floor back to you, Dr. Pollack. I'll finish up on a couple other things at the end of the meeting.
Great. So normally at this point, I would discuss recusal processes for action items, but we don't have any action items on the agenda today. So I'll move directly on to our guests. The update on nursing home response to the latest COVID-19 surge. So today we have with us Joe D'Amatos, President and CEO of HFAM, the Health Facilities of Maryland, and Kevin Hefner, President and CEO of the Lifespan Network, to provide updates on the nursing home industry's response to COVID-19 generally and to the Omicron variant more recently. The two associations represent the nursing home industry in Maryland, with HFAM largely composed of for-profit facilities and Lifespan largely representing the nonprofits. We'll pause for questions after Joe's presentation first. But Joe, welcome. Thank you for joining us. The floor is yours. Joe, are you still there?
You know, I've got that cup that says you're on mute. I should have used it today, even after 2 years.
Well,
Mr. Chairman, members of the commission, I am Joe D'Amatos. Thank you so much for having us today. I'm the president and CEO of the Health Facilities Association of Maryland. For the members of the public tuning in, HFAM has been around for 75 years. I've only been here for 12, although sometimes it feels like 75 years. I'm blessed to be here with my colleague, Kevin Hefner from the Lifespan Network. We work very closely together before, during, after the current pandemic. HFAM, I will say one other thing about HFAM. We do represent about 10% of the non-for-profits in Maryland, including the two largest. And I will say that Kevin and I have members in common and members that are different. And we very much, again, we complement one another, especially in this work during the pandemic. Levon, if you could go to the first slides, I'll try to get through this relatively quickly. This Omicron surge, as we all know, this most recent surge was a highly contagious spread of the COVID-19 virus. Now, skilled nursing and rehab centers have been on the front lines fighting COVID, along with hospitals and other providers since the start of the pandemic. In the case of skilled nursing and rehab centers, to some extent, assisted living campuses, and also to some extent, CCRCs, the reason why our skilled nursing and rehab centers were on the front lines is that we actually specialize in caring for Marylanders in need who often face multiple chronic conditions and who are often elderly. And we knew very early on that this virus, especially sadly, liked to target people with pre-existing conditions such as diabetes and hypertension, and especially the elderly. Thank goodness, going back to our first day of vaccination in Maryland, December 23rd, 2020, Maryland skilled nursing rehab centers, assisted livings, have some of the highest vaccination rates in the country. So while we saw that there were a significant number of breakthrough cases of Omicron, we had fewer cases in terms of the size of the outbreaks in most centers than we did, for instance, in the Delta surge. So the difference in the surges were that we had mostly smaller outbreaks, but they were pretty much in every center in Maryland. For those of the public listening in, we have 225 skilled nursing rehab centers in Maryland. Thankfully, just as high as Omicron went up, just as it did in other parts of the world, it is declining. We are in a better place than we are now. Probably the biggest way this particular surge hit us this last time was not in serious illness, was not in death, but was on the staffing side. Again, people that were fully vaccinated in many instances caught this virus. And that meant that rightfully they couldn't come to work. So in hospitals and in nursing homes, we actually had more capacity in terms of beds, but we couldn't use that capacity because we didn't have enough staff. Levon, next slide, please. So this is just really for the public that's listening in, just generally about occupancy in SNFs. You all should know that the vast majority of people who enter skilled nursing and rehab centers enter those centers from hospitals after an acute stay for post-acute care. And most of those people go home in about a month's time, maybe a little less. We also have a high percentage of people who call nursing homes their home. So prior to the pandemic, given aging dynamics and demographics, nursing homes in Maryland for the first time were sort of at about an 88–90% average occupancy. For a long, long time, we were in the 90s. And again, because of birth demographics, we were in the high 80s leading into the pandemic. Well, during the pandemic, occupancy, because procedures in hospitals were lower and people enter nursing homes from hospitals, during the pandemic, our occupancy has ranged from 58 to 78%. So presently it's about 78%, which is 6% better than the national average, which means that right now today in Maryland, we probably have about 22,000 people in skilled nursing and rehab centers in Maryland. Levon, next slide, please. So we wanted to take a look at the federal data and put things into context. So this is from CMS data. And if you look at 2020, at the start of the pandemic, in 2020 in Maryland, we had overall deaths of any cause in a skilled nursing and rehab center of 6,173 deaths. We had a total at year end of 1,865 deaths. We had a total of 36 deaths. In 2021, you see the direct impact of the vaccination that began on December 23rd, 2020, with a greatly reduced number of COVID-related deaths. Now, let me just say that every single death is to be mourned and mourned deeply, and every life saved is to be celebrated. But when you consider that at any given time in the last 2 years, between 17 and 22,000 people on any given day have been in a nursing home, I'm just proud of our healthcare heroes and the care that they provided. Next slide, please. So workforce and recruitment was a huge issue before the pandemic, from physician to certified nursing assistants. We've had a shortage of physicians in this country because of the number of slots. Applicants always exceed the number of slots available. We've had a shortage of registered nurses because we don't have enough registered nurse educators. There are a lot of people that want to be nurses. And then in GNAs, we've had, and CNAs, nurses aides, we've had hundreds of programs in Maryland and thousands of applicants. The matter there is matching the person to the right job and growing them in terms of their career. We're seeing across all employers the great resignation that we've read about and seen in the media. And that's true in healthcare. Here in Maryland, the Maryland Board of Nursing reported last year that 40,000 individuals that were licensed by the Board of Nursing exited the workforce in 2021. Next slide, please. I think in terms of labor and this recent surge, I think one thing that really hit home for us was there isn't one physician office workforce or hospital workforce or nursing workforce. In terms of licensed individuals and support staff, it really is one workforce, and they are tired and they are fatigued, and many of them have left, and we're all drawing on the same workforce. I won't read every bullet point. You can see here, and I make a reference to it in my deck, about the skilled nursing use and the fact that 37.5% of those surveyed expect that their organizations will continue to use staffing agencies. Levon, next slide, please. Now, I want to get something very, very clear. In 2020, the federal government spent an unprecedented amount in our fight against COVID across all platforms. And in skilled nursing and rehab centers and hospitals and other providers, they provided billions of dollars to support the fight against COVID. And that was true of nursing homes in Maryland. Now, let me just say here that those federal dollars in 2020 kept our doors open at a critical time. Now, people may be surprised to hear that the Maryland Medicaid rate to nursing homes was never adjusted as a result of COVID. There were a number of states that increased the Medicaid rate for the pandemic. Maryland was not one of them. Well, what Maryland did do, which I think absolutely saved lives, is they continued to pay the 4% annual statutory increase associated with the $15 minimum wage. The state provided hundreds of millions of dollars of testing support over the last couple of years, especially initially, and they supported with PPE. Financially, the state did three things. They advanced the FY22 4% by 6 months. The governor, at the end of last year's legislative session, in a supplemental, provided a one-time $26 million payment. And again, in December, the governor announced a $25 million one-time payment that is being released just now. In terms of context, it's important to remember that the skilled nursing and rehab Medicaid part of the state budget is about a $1.3, $1.4 billion item. Next slide, please. So in terms of funding, I will say that this is the most challenging in the time of the sector. And I'll just say this. Again, we are still largely a fee-for-service sector, highly dependent on Medicare and Medicaid for the majority of our rates. Costs are through the roof with regard to staff testing, PPE, and labor costs, especially agency labor costs, which you can ask me about in the Q&A, and revenues, because of the occupancy level, is in the cellar. So it is really just an unprecedented time in terms of that gap. Next slide, please, Levon. You're doing great. Thank you. Thank you very, very much. I think that the biggest learning from COVID is that the equal partnerships that we've all been talking about with this commission and the HSCRC and our day lives as the physician heroes and others on this call, we've been talking about further integrating our care. And I think the notion of equal partnerships across all settings is really driven home by our work in the pandemic. I know specifically, I couldn't have done this work over the last 2 years without my partnerships at UMS and LifeBridge specifically, but really with everybody, including the Hospital Association. This most recent surge, couple of last points, proved that we do not have adequate behavioral health capacity. Most of the people that were boarders in emergency departments during this most recent surge, and we had hundreds of them boarding in emergency departments, were related to behavioral health issues. And it just wasn't a good match to have them in our setting or other settings. And that was a challenge. I think it's important that we call out that the workforce challenge will be measured in years, not months. And again, I think just me personally, given my background, not just at HFAM, but throughout my career, the pandemic has disproportionately impacted communities of color, and it has shown a bright light on healthcare disparity and the social determinants of health. And together, we're going to have to redouble our efforts on that front. Next slide, please. So with that, I'll take any questions or comments that you might have. Thank you, Mr. Chairman.
Thank you, Joe. Questions or comments for Joe?
Hi, this is Marcia, Commissioner Boyle.
Yes, Commissioner.
Oh, thank you. Thank you for a very good presentation. Very concerned about the challenges you're the whole industry is facing. But it does bring me, to one point I've been concerned about with the nursing homes, long-term care facilities. You indicated the good news that there was a very good vaccination rate in terms of COVID. But what about mandatory vaccination for your employees? And I read in our annual report, for instance, we just got page 21, that in terms of influenza, the percentage of nursing facilities that have implemented mandatory vaccination policies decreased by 11% to 56%. I guess my concern is, with all the other challenges you have, that this may be an area that is loosening up. And then you're talking about, treating the most vulnerable citizens.
Commissioner, that's a very thoughtful question. Thank you. Thank you very much for it. I'll go the reverse on influenza vaccination first, and then go into COVID briefly. So influenza vaccination is a measure in Maryland's pay for performance system that incentivizes nursing homes to receive either a performance bonus or an improvement bonus. So for a long time in Maryland, that influenza vaccination has been prioritized, not just because it is the right thing to do clinically for our staff and residents and patients, but it is a performance measure for a performance bonus payment to nursing homes under Medicaid in Maryland. So I would say that I'm proud of the way that Maryland has conducted itself relative to the flu vaccination, and make that connection for you that it's actually part of our pay for performance incentive structure that we vaccinate a high number of our patients, residents, and staff. On the COVID vaccination, the national and the local associations, all of us, Kevin's association, mine, Allison's at Leading Age Maryland, our national associations, we all issued statements supporting mandates ahead of our members. And so all of our associations early on supported mandates. At the time that we supported mandates, we had some members that were for it and against it, but their associations, both nationally and locally, were for it. Eventually, our boards, I think Kevin's did the same, supported a full mandate. And I stood with Governor Hogan and the head of the system at a press conference when the governor announced that in the state of Maryland, that they would be a state mandate for the COVID vaccination. Now, and so I share that for you. Now, let me share one last point on that. In Maryland, as has been the case throughout the country, across all settings, in specific rural and other settings, because of misinformation, while Maryland's average is amongst the highest in the country in terms of both resident, patient, and staff vaccination in healthcare, we have pockets in Eastern Maryland, Western Maryland, and some neighborhoods in Prince George's and Baltimore City and County where the average isn't as high as 90%. So hopefully that answer is useful for you.
Dr. Pollack.
Thank you.
Commissioner Metz?
Yeah, Commissioner Boyle, I can probably add a little insight there to what Joe has spoken to. Full disclosure, I'm a member of Lifespan. I'm actually on the board. And I run a nursing facility in Western Maryland, as everybody knows. All of Joe's points, and thank you for all of that presentation, Joe. Very good.
Thank you, sir.
What we've seen with vaccinations, just to go a little bit with, I mean, he's right, Joe's right, it is tied to pay for performance. Our facility is ranked 10th in Maryland this year. We have a very good facility. It's a 5-star facility. We supported the vaccine mandates and were able to get right around 90%, even in Western Maryland, which we were pretty happy about. That took a monumental effort by myself and our director of nursing to just meet with our staff repeatedly one-on-one. There was a few folks that had legitimate health exemptions and remainder sought religious exemptions. So we had pretty good success there. Joe's correct in some of the misinformation and the politics that came to play really impacted even our industry, especially in populations like Western Maryland, where there's such a conservative base, or Eastern Shore, where there's such a conservative base. In regards to flu vaccinations, we've seen some pushback this year on flu vaccinations, and I attribute it to two things. And we've had pretty good success there traditionally with our facility. Part of it is vaccine fatigue. They've been shoved vaccine mandates and been pushed through that so much that even some folks that agreed to be vaccinated for COVID chose this year to say, I'm just not doing flu vaccine. I'm just not going to do it. We're trying to educate them on that. Part of it then is tied to and this is going to be unfortunate. I think it's probably going to trickle all the way down to our children entering school. There's going to be a national pushback on all vaccinations because of the misinformation on this vaccination. That's my opinion. And I think we're going to see some of that. We're going to see folks who didn't think twice about vaccinating their children for school are going to now push back because they believe it's politically correct or in their best interest to push back against the state. So I think both of those items come at play there. But I just wanted to weigh in there because I'm living through this. Thanks, Dr. Pollack.
Thanks. I just want to note that Commissioner Jensen, I believe, has joined the meeting. Are there any other commissioners who weren't here for roll call who have joined? Great. Question, Joe, and I'm not sure how easy this is to address, but you talked about the challenges with staffing during the Omicron surge that were related to absenteeism and the Great Resignation and all the other challenges. In the hospital side of the equation, that resulted in a substantial number of agency nurses being hired, travelers, et cetera. Can you talk about the degree to which the nursing homes became dependent on agency and travelers, if that's a thing in the nursing home world, and the degree to which that was limited by the finances of the challenge? In other words, when you move to agency,
Yes.
your variable nursing cost goes way up, and we addressed a pretty substantial bit of that on the hospital side of the equation, probably at a higher rate than it would have cost to address it on the nursing home side of the equation.
Yeah, no, it's a really thoughtful question, Mr. Chairman. Thank you for asking it. So we actually looked at Medicare cost report data, and we actually polled our members. So it looks like in skilled nursing and rehab centers that use of agency has more than doubled, and the factor of agency has also increased in percentage as well as price. So let me just get out of that stumbling and talk to you about three different variables. So use of agencies over the last 3 years for staffing for GNAs, licensed practical nurses, and RNs more than doubled in our sector in Maryland, the use. Pre-pandemic, the most common use of agency in our setting was per diem. I just need somebody to come in and take this one shift, and maybe the hourly rate for that per diem was $68 for an RN as opposed to $45 for an hourly RN. So maybe that was the difference. And it was a single percentage issue in your center. So if you were sort of not in the average, it could be 6, 7, 8, 9%, which was a problematic number. So now I visited a center on Thanksgiving Day last year that usually used to have zero agency, zero, on Thanksgiving Day that week. Now, mind you, it's Thanksgiving week, but they're a pretty good center. They were at 0 pre-pandemic. They were at 80%, 80% agency. Now, I'm concerned about that, not just about the financial sustainability, but because of the continuity of care, when on any given week, you suddenly have 80% of the people that are not direct employees. Now, that was an outlier, and that was a peak moment, but it was a problem. Now, the third variable, cost, and I speak to Cindy Kelleher all the time at UMS about this. When you look at per diem and long-term temporary staffing now, for instance, for a registered nurse, that registered nurse that on the per diem basis used to cost $68 an hour, now costs $180 to $200 an hour, right? So that is not sustainable for the hospitals, for the skilled nursing and rehab centers. Now, this is in addition to nursing homes doing everything they can, and Jeff can speak to this, paying bonuses, paying shift differentials, paying bonuses for people maintaining their whole 2 week of their schedule, all kinds of innovative things, and still needed to use agency. So it's a problem. And I think the pricing will level out. I think we're starting to see that level out. But again, the reliance on agency is more than doubled and the costs have pretty much tripled. And that's not sustainable in hospitals or in nursing homes.
Dr. Pollack, Joe's correct in everything that he's stated, and Kevin might be able to speak to this as well. I do believe there's some legislative effort to rein in Annapolis, to rein in some of the, I don't want to call abuses in this area. That's probably the wrong word. But some of the price gouging, the perception of that going on, where, as Joe mentioned earlier in his presentation, there's only a finite number of nurses and aides, et cetera, available. And when they're recruited to agencies, instead of coming directly to work for my facility or your hospital, say, they know they're going to be paid premium. Those facilities are going to be charged premium, and it's all coming from the same pool of workers. So I think legislatively, Annapolis is trying to address some of that. Don't get me wrong, agency obviously is going to always have a place in our industry, but I think that it's been recognized that perhaps during an emergency situation, there needs to be some controls set in place to more closely monitor that.
So the challenge with that obviously is that these employees cross state lines pretty regularly. And if you make the market, if you take the market away for them in Maryland, it will be even worse. We'll wind up with all of them going to other states to work agency, and nobody left to work in Maryland. I'd be concerned about a legislative approach to that problem. It's a market problem,
It's a national, Mr. Chairman, it is a national problem. There is legislation in Annapolis, but it is a national problem. Our members and our American Healthcare Association is working to issue not just with Congress, but with the Federal Trade Commission to address the issue nationally, because as bad as it is here, there are pockets in the rest of the country where it's way, way worse. Texas near the border, strangely enough, is much, much worse there. And there, it's not just the competition amongst healthcare providers, it's the federal government as an emergency contract hire of medical professionals. You got that added variable on the border there. So it is a national problem, and we hope the FTC and Congress will step in addition to what the General Assembly might do.
This is Commissioner Bhandari. I have a couple of nurses. I asked them the question, and their analogy was, when you book a ticket on airlines last minute, you have to pay a premium price. It's like a demand and supply. And their concern was, what is wrong with that? And they were thinking the nurses were underpaid and they have to work very hard. So I think that's one of the concerns. I can say on my behalf, physicians are in the same boat. We have a lot of doctors retired, and physicians are underpaid. For example, I can tell you myself, I work 16 to 18 hours a day. I can't keep doing that forever. And it's just a matter of, I think it's probably the fair compensation. I can tell you in information technology, they charge $200 per hour. That's a lot. and they don't have to do any kind of training what we have to do as a physician. Their liability is not as much as ours are.
I just want to add that Commissioner Cheatham has also joined the meeting. Why don't we go ahead and move on to the second presentation? Kevin Hefner, President and CEO of Lifespan Network, and then we'll pause again for question after Kevin's presentation.
Well, thank you, Dr. Pollack. I want to thank Joe DeMatos as well. What a great partner through this process. You know, the last 2 years have been a long decade, I think, for all of us in many ways. And I'll just add to the previous conversation about nurses, just speaking anecdotally, and we've been hard at work on this collectively. We've seen examples, even in Central Maryland, where direct care workers who have been working in a facility for decades, 10, 15, 17 years, have had agency nurses come in at a higher pay rate than they were making. And so you can predict the dynamic that's taken place where nurses who have been with facilities for decades will hop over to agency and then work for their same facility at a higher rate. So it creates incredible financial pressure for all of the providers. I want to thank Dr. Pollack and Ben and the entire commission for allowing us to have this conversation today. I think it's an important one. One of the silver linings, Levon, if you could switch to the next slide, please. And thank you for your help with navigating through this. You know, back in June 2020, which in many ways seems like yesterday, but in other ways seems like decades ago, I think we were all searching for ways that we could help, searching for silver linings in a global pandemic. And one of the silver linings that came about at that time and has remained since is people coming together, the associations that represent this space, Joe, Allison, myself, and all of our boards and members really did pull together and have remained together on a regular basis to address some of these important issues. And so that's been a little bit of a positive. I will say, if you remember back to June 2020, I'm going to talk about some programmatic things that we're doing now and that we were doing then. Back in June 2020, we were well along with sourcing PPE with domestic companies. You remember the stories of companies who were changing their manufacturing operations to be able to get PPE into the hands of hospitals and nursing homes more quickly than they could when sourcing from China. And we had a great deal of success with that. And even to this day, continue with the three associations in this space working towards getting PPE into the hands of the people who need it. Obviously, things have changed since 2020, but when I walk into my office tomorrow, I'm going to see more boxes packed up and ready to go for providers in long-term care who need PPE. So we continue to do that, and it's truly been a group effort to make it happen. Ironically, the PPE that we're sourcing now is actually coming from MDH. When PPE ultimately did arrive, there was a surplus. And so thanks to the Department of Health for working with us in order to get those much needed items into the hands of the people who use them every day. Next slide, Levon. So we took a programmatic approach, and I'll tell you just very briefly. As Joe mentioned, Lifespan and HFAM, as well as Leading Age Maryland, we really complement each other. There are three associations in our space. We all have different skill sets, different things that we bring to the table, and we've managed to work together and utilize the skill sets that we have in tandem, and that's been very, very effective. One of the things that Lifespan and our members, we've got about 300 institutional members, but a very diverse group. We have nursing home members, as Joe mentioned, but we also have assisted living members, hospice members. We have home and community-based services, adult day, home care, and even some hospital members. And I'll mention that in addition to Lifespan, HFAM, and Leading Age Maryland, we've also worked very closely with the Hospital Association and CRISP, as well as HSCRC and the Maryland Healthcare Commission. House Bill 1022 was introduced during this legislative season, and it's really, its introduction is following some hard work that we collectively did for about 1.5 years to attack one of what I believe is the biggest challenges that nursing home operators face, which is how to deploy very limited resources in intelligent ways. It's a very, very challenging burden for nursing homes to do the reporting in multiple areas that they have to do, takes away from direct patient care. And so we set about trying to find ways to help alleviate that and deploy those limited resources in an intelligent way. So House Bill 1022 really supports Maryland's focus on care transformation by creating a way to partner with data technology providers in order to anticipate where pandemic communicable diseases might be popping up. As Joe mentioned, virtually every nursing home in Maryland has had outbreaks during the pandemic. And being able to scrape data on a daily basis and identify where hotspots might be popping up is an important way for us to deploy not only the resources of the nursing home that might be having an outbreak and nursing homes in that immediate area, but also the resources of the Department of Health, technical assistance teams, as well as other teams that go into nursing homes so that they can deploy those resources effectively. What it's really all about in this case is reducing unnecessary hospital admissions. And I'll talk a little bit more about what that means here in a moment. Next slide, Levon. So I mentioned surveillance. There are software providers who can identify on a daily basis as much as 5 to 8 days earlier than present tools allow where there might be outbreaks. So you can imagine the importance of being able to get those resources where they need to be 5 to 8 days earlier, so that instead of having 50, 70, 90 cases of not just COVID, but other communicable diseases, you can deploy resources much more effectively and keep people out of the hospital as well as keeping them alive. So the technology allows those data scrapes to take place on a daily basis, takes the early information that anticipates where outbreaks may be, O2 saturation, respiration rates, elevated temperatures in large numbers, and identifies those hotspots so that we can deploy the resources effectively. I mentioned also coordinating as being really key, but communication is so important now that we're at a point where there's technology that allows us to identify this in advance of where we are now. Next slide. So the other thing that technology can do is reduce readmissions and admission to hospitals. So the software mines electronic health record data, anticipates where there might be weight gain with a history of congestive heart failure, where a resident might have not had a bowel movement for 72 hours, changes in ADLs. Those can be anticipated, fed to a call center, and send push notifications directly to nursing home clinical and leadership staff. So administrators, directors of nursing, medical directors, so that they have on their phone notifications, for instance, that like Mrs. Jones has not had a bowel movement in 72 hours. She's going to be going to the hospital very shortly if we don't intervene. So it enables the operators to deploy resources directly to Mrs. Jones and to mitigate whatever health condition she may have. Call center works with the nursing home, making sure protocols are followed and reduces hospitalizations dramatically. One of the software operators that we've talked to, there was an HSCRC grant project in Montgomery County. It demonstrated a significant decrease in admissions, lower cost of care, and the data is available and really supports this as an important way to go. Next slide. So the cost, the bill was approved. Actually, the governor allocated $5 million in his budget for this coming fiscal year to cover the software, the call center, the support. We had a great meeting with the governor's team just a couple of months ago, fully in support of this, and the dollars are eligible for a 75% federal contribution. So we've been working to coordinate with CRISP to include epidemiology staff to look for pandemic hotspots and to administer the program. Here's how it will basically work. We will screen proposals from some of the software operators. There are at least 4 of them that exist that can do this. Once a determination is made, which software operator that will work with, CRISP will administer this along with Lifespan. It will put this technology in every nursing home in Maryland free of charge, along with all the support that I described that comes with it, and including a yearly evaluation of results by an outside party. Had a great conversation with the governor's staff. As I mentioned, they said, not only are we in support of this, but if you need more dollars, please let us know and we'll get them to you. Next slide. So the other issue, and Joe covered this in great detail, I'm just going to mention one program that we're working on. As I mentioned, programmatically, what are we doing? Well, the Data Hub project is one thing to deploy resources effectively and to make the best use and reduce hospitalizations, as well as anticipating hotspots for communicable diseases. Well, staffing is a big challenge. And one of the things that we looked at early on in the pandemic is how can we find a way to get nurses certified in more meaningful, in more effective ways. Well, for 30 years, and Levon, if you can just click again, we moved our office recently, and I won't bore you with the details, but I will tell you, we found one of our member surveys from 30 years ago. It looked like a blue book. Next click, Levon. But we asked, what keeps you awake at night? Workforce was the same issue 30 years ago as it is now. In fact, it's been exacerbated. It's worse, as many of you know. And so we set about trying to find ways to get more nurses into employable situations, to get them trained and to provide them with the support they need. Next slide. So historically speaking, and you can click all the way through, Levon, you're very familiar, I'm sure, with all of the barriers that exist. Transportation, if your local community college is not offering, is offering a program, but you don't have transportation to get there, you live in an urban environment, you can't go, you can't take the course. If you have childcare issues, if you have scheduling problems, if you don't have the money, it continues to baffle me why it has been so historically difficult for people to get into the field. We've made it difficult by requiring them to get certified before they start, before day one on their job, and to spend $1,000 or $1,200 to get certified. It's just a non-starter, as well as other challenges. Next slide. Other hurdles that exist, new program, anything new is always under scrutiny. Maryland Board of Nursing has to approve, Maryland Higher Education Commission has to approve. How do we scale it? How do we make sure that we don't lose them right after they start? And as Jeff will attest, it's not an uncommon occurrence that a nurse will take a job, show up on the first day and then never come back again, or not show up at all. There's competition among facilities for the same staff. These were mentioned, we're close to, in Western Maryland, bordering states. We're close to bordering states in Southern Maryland. So lots of challenges there. So we set about trying to eliminate the hurdles that exist, and we came up with a hybrid nursing certification program, and I'll talk to you a little bit about that. As well as being in working in conjunction with HFAM with Leading Age Maryland. Everybody's been in support of this, and we've really been setting about this heavy lift together. Next slide. So here's how we've come about mitigating the barriers that exist. Transportation. The program that we've developed that has been approved by the Board of Nursing and is nearing final approval by MHEC. The content the didactic content is completely online. If you live in Western Maryland and you have any of these issues, transportation, childcare, schedule, well, we started to figure out ways to attack those problems. Didactic online content is one way so that you can do the nursing certification course wherever you are. It's pausable so that if you go through your weekly content and you're only halfway through and you've got childcare issues, you're able to pause and come back to it. Very importantly, the content is asynchronous, meaning that if you need to do the program at midnight or 2 in the morning, you're able to do that as long as you stay on pace. Also importantly, the program is fully scholarshiped. We worked with nursing home partners, foundation partners to make sure that everyone who goes through the program will be able to do it free of charge. And at least now with the temporary nursing assistant program, they're able to do that after they've started earning a paycheck. So it removes the financial barriers. There are also office hours for the instructor and a support team to meet all those needs. Next slide. So in 2022 and beyond, we're prepared to launch this program very shortly. It is the first hybrid asynchronous program anywhere in the state of Maryland. There are other online programs that exist, but they are synchronous so that if you have a scheduling challenge and the class meets during the day while you're working your other job, you're able to take the course. MHEC's final approval is expected shortly. We've got lab equipment in transit for the labs. We'd also like to go directly to using virtual reality. So even the lab portion would be able to be taken from home or from wherever you are. In terms of the marketing plan, how do we get more people into this field? Well, I'm part of the Governor's Workforce Development Board, and they've pledged their support to pushing out information on the program to unemployed Marylanders, to getting people into the field of nursing from whatever field they may have been in, whether it's hospitality, the restaurants, hotels, into a field that needs them desperately, and providing all the support that entails. We also have worked with providers to identify temporary nursing assistants that they'd like to put through the program. In fact, I got an email earlier today from one of our members wanting to know when we were going to be able to launch because they're so eager to get people into the field. Expecting to launch by mid-year. And so we're very excited. Again, back to what I discussed earlier on, using technology to deploy resources effectively, using technology in order to get people into a field and eliminate some of the barriers that exist to that are all positive things. And so I guess, from my perspective, one of the silver linings of the pandemic has been we've thought more creatively, we've worked together, we've collaborated to come up with real solutions for nursing home operators. And it really has been a group effort. Last slide, Levon. So there's been a lot of concern, a lot of conversations around a recent spate of new nursing home acquisitions and transfer of ownership, and how we go through the process of approving new nursing home owners. So Lifespan put together a working board and came up with some recommendations for the commission in order to vet more effectively, we think, prospective nursing home owners before they come into Maryland. It's no secret that many operators in New Jersey have recently moved into Maryland, lots and lots of new nursing home owners. And so our recommendation going forward is that there would be a mandatory interview process for new prospective owners so that the commission and we know who they are. The principal owners, not just the shell corporation or the corporation from out of state, real people who the commission's able to talk to. And then I won't detail all of these, but 3 other recommendations for requiring submission of first-year budget, requiring submission of quarterly financial statements on staffing in particular to make sure that staffing levels are maintained, and then a recommendation for a request for information from new prospective owners and ownership groups related to nursing homes they already own in other places. What has their track record been? Have they had adverse events take place in their nursing homes in other states? So that's all valuable information to have. So I'll just wrap up by saying I'm very appreciative to our partners, to HFAM, Leading Age Maryland, the Hospital Association in particular, the commission for allowing us to vet these important issues and to share some of the things that we're doing. Thanks, Dr. Pollack.
Thank you, Kevin. Questions for Kevin?
Dr. Pollack, I just have one comment to add. I want to preface it by saying it really through the pandemic, everybody's dealt with it unprecedented over the last 2.5 years. I want to say, we're very appreciative of the different things the state has done with TAT teams, with PPE, with financial influxes, and what the associations have done, both HFAM and Lifespan, collaboratively to help us. There is a real challenge with staffing in nursing homes, and it's more challenging now than it has ever been. And I'm appreciative of the efforts, this unique effort that Lifespan's attempting to develop for training frontline staff. I've worked with Kevin on this acquisitions and transfers of ownership issue, which is becoming an issue that will have to be dealt with at some point. And I know it's in its infancy with some of the ways to combat some of those situations. But one of the things I did want to say, and I mentioned this to both Dr. Pollack and Ben early on in the pandemic, now that we've kind of come full circle and survey teams are reentering buildings, there's a genuine fear that after 2 years of folks sticking through this and working through this in some conditions that are almost warlike, absent the shooting, that facilities potentially blamed, the healthcare heroes who will be left behind or blamed at the end of the day. And there are poor operators, and there are folks that don't do things so well, but there's an awful lot of good facilities out there that work as hard as they can every single day. I would just suggest that the state regulatory agencies temper some of that as they come back into facilities and recognize what these teams of people have been through. I just wanted to make that statement. Thank you.
Thank you. One question from the chat, Kevin. Are there prerequisites for these training programs that are difficult for people to meet?
It's a great question. The only prerequisites that exist are those that currently exist for in-person programs. So community colleges, private career schools, essentially that people who want to take the course undergo background checks and that they that they provide proof of vaccination and a couple of other medical screening processes that all of the other programs have in place that people have to take.
But no educational prerequisites that are onerous?
No onerous educational prerequisites.
Thank you. Thank you both. Commissioner Dorgan, I see your hand up. I'll take the last question.
Thank you. And just a couple comments to Joe and to Kevin. Thank you very much for this information. 19% of, I guess, our budget that we get is from the nursing home industry. And I've always wanted to make sure that the industry felt whatever support that the MHCC could do that, that is being done. And if it's not, it would be, as a commissioner, I'd really like to hear that. Just from I could ramble for a long time, and I pledge I won't do that, but just from a disclosure standpoint, I had the opportunity in the 80s, back in the days of iniquity, to be involved with 2 nursing homes as an owner. And unfortunately, the things I'm hearing today are really not much different in regards to support. And so much of it, in my opinion, comes from actual support for the nursing home industry to be able to successfully do what they're supposed to do on a regular basis. We have a very lot of protection for the hospital industry, but there really isn't. And I'm, I guess, and I realize this is a meeting of where you have to be politically correct and all, but there's a lot of your folks, I think, who might suggest that nursing homes really haven't gotten the support at the government levels at all to provide quality care during this period of time, let alone before. Knowing what the margins were, and I do realize it's becoming more of a for-profit industry, and the small nursing homes are going away, and that's just part of life, I think. But I just, I think that this new program is great. It's just, I hope you have the ability within nursing homes themselves. Jeff's talked about it as he talked before, to be able to afford the resources to come in to do these things, and the expertise and the time involved to make it happen. What Kevin, you're trying to do with, these new programs, because it's critical, and, it's here for life. And, this hospital at home and all the other things are wonderful. But I mean, what you do is so valuable for so many of our folks, and as we see, so many are not getting the support they need. But I do appreciate the opportunity to have heard from you both, and to hear what you're trying to do. My best.
Thank you.
Thank you.
Thank you to Joe and to Kevin for your time. We know you have to get back to other activities, so we'll move on.
Thank you all very much.
Thank you. In December, the Board of Public Works approved a 7-year contract with On Point Health to continue development of the Maryland Medical Care Database. 18 states have data systems known as all payer claim databases that are similar to the MCDB, the Maryland Claims Data Bank. The new MCDB contractor, On Point Health, supports 11 of those states, including Maryland. James Harrison, President and CEO of On Point Health, will provide an overview of On Point Health, briefly outline their work in other states, and describe their plans for working with MHCC. Jim, welcome.
Hey, thank you very much. Appreciate the opportunity. Good afternoon, everyone. And thanks for driving the presentation, Levon. Next slide, please. Just a brief introduction to On Point Health Data. We're an independent nonprofit, which is unusual in this space. We're based in Portland, Maine. We've been a front runner in APCD development and support for many years. Maryland predated the system we developed in Maine, but we were one of the early developers. When I joined the organization, Ben was one of the first folks that I met and admired the work you were doing in Maryland. So really appreciate the opportunity to provide some technical support for your organization and stakeholders. We bring, I think, unique depth and technical expertise. We specialize in all payer claims database, having developed more than 50% of the established APCDs across the country. Next slide, please. We're supporting APCD clients in 11 states, and they make up both state mandated or state sponsored, like Maryland, and voluntary. So there's a mix across the country, and we support both. We are working also in the federal government space where the quality and cost measures contractor for the Comprehensive Primary Care Plus program, one of the alternative payment models under the Innovation Center. Next slide. We're collecting data from 250 health plans every month across the country. And those included when we bid on the work in Maryland, those already included 19 of the 34 payers that are submitting to the Maryland APCD. That really helped with onboarding. We're collecting in Maryland, you probably are aware, multiple different data types, so file types, eligibility data, medical and pharmacy and dental claims data, provider data, and member data from in a data exchange process that has been well established with CRISP. Next slide. So we built a cloud-based infrastructure that really is built to scale. We're handling the smallest state-sponsored APCD in the country, in the state of Vermont. We're also managing the largest APCD in the country, in the state of California. I give you an example to demonstrate scalability and performance, which will be leveraged by the MHCC solution. We received a Kaiser file in July. The average file size for them was 17 million rows, which is big data. It was exposed to 700 of our validations, and that file was processed in less than 14 minutes. It's a best of breed technology stack geared toward the type of data we're integrating. I wanted to point out as well that security is critically important to you all and important to us. We're HITRUST certified, which is a common security framework and the gold standard among health plans, in particular, exchanging data with their technology partners across the country. Next slide. I just point out here a few of the boxes to demonstrate the breadth of work we do with the data that we bring in the door, not only on the left side that we're validating and ensuring the quality and completeness of the data coming to us from your participating health plans, the mandatory submitters, but also a lot of enrichment occurs in the processing of those files. Provider indexes, consolidation of claims, a lot of analytic enhancements like groupers and use flags. MHCC is considering the addition of performance measures. We have a measures engine. There are a number of categorization groupers that will be run against the data, and all of this to make the data usable and useful to end users, the state's own analysts, our analysts, and those the state permits to undertake research on their behalf. At the end of the line, we refresh on a quarterly basis. Currently is the scope of work, a quarterly refresh of the data that lands in a contemporary cloud-based infrastructure that's dedicated to the staff of MHCC. We call that an analytic enclave. If you move to the next slide, the enclave environment is built with all the latest security, HITRUST, SOC 2, the alphabet soup. We are provisioning, you can keep going with, I think, a couple more. We're provisioning the tools the state required and are used to using, including SAS and a SQL type, and a SQL type querying software. To access this environment, which there's a lot of sensitive data, requires multi-factor authentication and all of the security controls that have been signed off on by the state. Next slide. one of the tools that business users, folks like myself, Ben, Ken, others on the team will work with is a business intelligence tool that has been designed for a lot of the reporting that are typical for an all-payer claims database. The reporting is designed in 5 different domains: provider, demographics, geography, that type of thing. And this is just an example of the user interface that an end user would see and be able to filter and define their own reports as well. Next slide. Ben asked me to give you a quick progress report and to recap the value that we think we're bringing so far in our role as the state's data aggregator and analytics contractor. So we executed a contract with MHCC in October, and since then, I feel really good about the progress we've made and we're making. We we developed a transition plan and have been nailing the milestones that are on that plan. We stood up an instance of the software that we deliver data integration services with called OnPoint CDM. It's been configured to your data collection specifications. We released the data submission guide to your data submitters and other stakeholders. It was in December. We've onboarded and registered all 34 of your payers, and each payer may have multiple submitter codes to address their various adjudication platforms. We launched your analytic enclave. We opened the APCD platform at the beginning of January, and an update as of today, we have 28 of the 34 health plans that have already submitted some sort of file. They're testing, they're submitting live files, production files, various stages of completion, a lot of back and forth with our operations analyst that is dedicated to MHCC and supporting those health plans. Like us, MHCC really views and treats their submitters as customers, and we hope to live up to that standard as your technology partner. We've completed a project management plan. We've migrated, tested, and relaunched the Where the Cost website so that you can check that's up and running in a new environment. And the historical data from your previous technology contractor has been transitioned to the MHCC's new environment, and that data is being mapped and tested and gradually will be over the next weeks fully integrated into the new MHCC data structure. Next slide. Ben asked me to relate how we would be helping Maryland, how we are helping Maryland, and these are the thoughts from our team. First, I feel really good about what has been a relatively seamless transition to a new technology platform. We don't take full credit for that. That's been a collaboration with MHCC's capable staff and their contracted project management vendor Friedman Healthcare. We've provided hands-on submitter support, which is required under our contract and our way of doing work with day-to-day hands-on support with submitters. We're producing a robust set of analytic enhancements that I think the data we deliver will be much more usable. I'm hopeful that researchers and analysts at the state will be able to make best use of the data. They'll have the training and technical support they need from our team. We'll provide transparency in all the business rules to the state's analysts and data submitters. You know, what are our data quality validations? How do we assign a ED use flag, or how do we aggregate inpatient claims into an inpatient discharge record, that level of detail. We hope to accelerate the data refresh cycle. There are opportunities to streamline, we think, the exchange process with CRISP and other opportunities to more rapidly bring data to the state's use. We're leveraging the most contemporary technology in the analytic enclave. We have a BI solution that I believe the state will find very useful. We've deployed that in Vermont, in California, and in other states, and continue to enhance it over time. It's focused on use cases that are typical of all payer claims databases. And we see opportunities with your team to enhance some of the reporting we're contracted to deliver, including the privately insured report that is well underway and I think will be delivered in the next couple of weeks. And I think the state will be very satisfied with the level of flexibility in our data architecture, the ability to slice and dice the data in useful ways. Next slide. I was just going to run quickly through a couple use cases to give you a flavor for the BI's business intelligence solution we'll deploy, the reporting that we'll customize to the state's needs, or the state will be able to generate on its own. For the state of Washington, we deployed a dynamic public health focused reporting tool. This particular view or visualization is focused on chronic condition prevalence. Next slide. In the state of Vermont, we generate regular updates to their community profiles. So they do a lot of geographic and provider-based reporting where they're looking at the cost and quality variation across geography, providers, conditions, that type of thing. Next slide. We do linkage quite often, and that's something that the state team has in mind. In this particular case, we're linking poverty data with measure results around access to care and looking at the relationship of poverty and access to primary care. Next slide. This was a report around primary care spending we felt very proud of. We were selected by all 6 New England states to perform a primary care spending analysis. And this is just one of the visualizations in the final report. The new NESCO is the New England State Consortium of Systems Organizations. Largely, all of the Medicaid programs across New England get together to collaborate around system choices and analytics that are of benefit across the region. This is one. Next slide. And that's it. And I'd be glad to take any questions if there's time, Dr. Pollack.
Yes, there is some time. Commissioners, do you have any questions?
It's a dull subject, isn't it?
It's not. Well, the data is not dull. The nor is the our ability to analyze it. Can you talk a little bit about what perhaps how you've seen some other states take a look at the data, particularly with regard to linking claims and social determinants, and how they've turned that into actionable information?
Sure. So just a quick example, in the state of Washington, they have, I think 5 of the 7 million lives in the database. They're missing, some of the same ones that we would be in Maryland, self-funded ERISA claims, some of the federal data, but it's a robust data set, and you'll have a very robust data set. And so the linkage at the various levels can be efficiently accomplished. So first, linkage is at the most granular level, done at the patient level. Social determinants data is often not available at that level of granularity. If it is, you could link at the patient level and really drill down. In the case of the visualization I provided from Washington's Tableau reporting, they linked poverty data from the US Census at a geographic level to the APCD, the All Payer Claims Database. And they were able to look at the performance measures, a lot of HEDIS quality utilization cost measures, where it makes sense against the race, poverty, that type of thing. One thing that's interesting in California, we just completed, we did the same thing for Connecticut, and it could easily be done for the state of Maryland. It may be underway, but there are algorithms where race is not often collected or not as fully populated as it might be in the claims. You can impute race and ethnicity through algorithms that look at geography, names, and impute, an estimated race. That's we collaborated with RAND to do that, and with UConn in California, RAND in California, UConn in Connecticut to run those algorithms. Other questions?
Dr. Pollack, I just wanted to make a point. I think you can hear me?
Yes, yes.
Yes.
Okay.
So I wanted to point out, and I did tweet out or did put in the chat, the report on primary care that OnPoint did with the 6 New England states. But that is an analysis that has gotten quite a bit of attention, given interest on setting or understanding levels of primary care spending. What was special about this was that we've looked at the private sector, privately insured populations. The NESCO group looked at Medicaid, Medicare, and the commercially insured, and it's kind of consistent with our view of looking more broadly at populations today, not just the privately insured population. The second thing that Jim mentioned, I think is attractive to us as we look at equity, is that we do get HEDIS measures from the health plans, but there's lots of questions about performance of plans by population. And what we'll be able to do is generate the HEDIS measures for subpopulations within the privately insured or Medicaid population, which will really allow us to focus more carefully on health equity across payer platforms, which I think is the direction everyone wants to go. So just wanted to provide that as an update and an insight on what we hope to do in the next couple years.
Thank you, Ben. And thank you, Jim. I appreciate your
Sure.
presentation. All right, agenda item number 5. Tracy DeShields, Director of Policy Development and External Affairs, will give us a legislative update and review the bills that are a priority for the commission and coming up for bill hearings in the next couple of weeks. Tracy, the floor and the screen are yours.
Great. Thank you very much. Good afternoon, everyone. Good afternoon, Mr. Chair. And first, I'd just like to say that the legislative session is cranking along. MHCC is extremely popular. Sometimes that's a good thing. That's a very good thing all the time, actually. Anyway, so just some quick facts, if you will. February 25th, which is tomorrow, is actually day 45 in the legislative session. And so those of us that work around legislation, that's always kind of an exciting time because we're like, yeah, we made it through the first 45 days. And then the next day we realize we have to make it through the next 45 days. And that's really where a lot of things start to, bills are moving. There's a lot of discussion on amendments to bills, what's actually gonna move forward, what's not gonna move forward, that sort of thing. So there's a lot of action happening at that point. At this point in the legislative session, believe it or not, about 1,200 bills have been introduced in the Senate and over 600 in the House. We are tracking approximately 147 bills. There are probably a few more than that as of today. And also, I just wanted to let you know that there are specifically, aside from the 2 bills that MHCC specifically put in, which is our user fee bill and our HIE bill, there are 13 bills which specifically have MHCC taking on or doing a particular task. Many are studies or convening work groups to do a study and reporting back to the legislature in 2023. So with that, Levon, next slide, please. So I just want to go over some of the things that have occurred to date and are occurring today. There are a couple of bill hearings occurring today as we're in our commission meeting. The first, with regard to our user fee bill, the bill was both heard in the House and the Senate. It is right now, the committees will be considering the bill in the next day or week or so. Today, our user fee bill is up for a vote in Senate Finance. There'll be discussions about it in subcommittee probably next week, perhaps in HGO. House Bill 213, our health insurance exchange definition bill, actually was voted out of HGO. It was amended. These are amendments that we worked out with carriers and with the Health Education and Advocacy Unit of the Attorney General's office. And so we're happy with that. And yesterday it passed on third reader in the House. So it will now be forwarded over to the Senate chamber and assigned, most likely to Senate Finance. Also on tap is we provided a letter of information on this particular bill. This has to do with telehealth, in particular with regard to out-of-state healthcare practitioners. The House bill was heard last week or the week before, last week, I think. And again, we submitted a letter of information. The Senate bill was up this week. And we submitted a letter of information. Also on Senate Bill 591, this has to do with the Patient Safety Center and establishing a non-lapsing fund, which essentially would be $1 million appropriation each fiscal year to the Patient Safety Center to help support and fund its core mission requirements. And so this particular bill, Ben testified on it along with a representative from the Maryland Hospital Association. There was a panel. There were some questions because some of the committee members in the Senate, on the Senate side, had not really heard about the Patient Safety Center. So it was a little bit of an educational moment for them to kind of learn about something they hadn't heard before and try to understand it a little bit better. This bill is being heard in the House March 9th. And there is a House bill that came out a few weeks after the Senate bill, that hence it's not on here. But that will be heard in the House on March 9th. And again, we will provide a support and oral testimony on that bill in the House. House Bill 378, that also had a bill hearing. It was heard. We did provide a letter of support on this. This would require us to form a work group to look at the palliative care services across the broad spectrum with regard to palliative care, not just within a very narrow setting such as in hospitals, but to look at it broadly across the spectrum. Senate Bill 734. This is a bill that we decided to weigh in because a number of the things outlined in the bill for this particular commission to do, MHCC currently does. And also there are aspects of it that are currently being conducted within the department in the Office of Primary Care. So that said, we did work out amendments along with the department, basically gutting the bill and having the responsibilities that would go to this new commission come under the domain of MHCC at this time. So the bill hearing was yesterday. Ben did testify on that. I don't know, Ben, if you just wanted to make a comment or not, or with regard to.
Yeah, just to say that it did seem to have some momentum. The commission's data systems would be used, which would have been the commission staff would have been expropriated to do the work. The commission has had a long-standing commitment to primary care, and in discussions with the sponsor, indirectly largely, and the department, we concluded that it would be better to be placed under the Healthcare Commission. It also achieves a priority of the senior staff, which is to be very cautious about committing to conduct work that's not under the direct responsibility of the Healthcare Commission. We obviously want to collaborate, and I'm sure the commission wants us to collaborate with other stakeholders in Maryland government, but it is important that the commission take responsibility and be accountable for our strategic priorities in particular, as well as our statutory duties. And we felt it was more appropriate that MHCC take the lead on this particular area.
Okay, great. So the next bill is House Bill 747. So there's been a lot of activity around this bill. Our position on the bill was to oppose because a lot, again, the information or the data is available and it created some duplication and redundancy that wasn't really necessary. So there was a meeting with the Delegate Kerr, who's the sponsor of the bill, and along with some proponents on the bill. And so we had, I thought, and I think Ben would agree, it was a very good conversation. And so interestingly enough, they came to us last night with amendments. So the amendments actually changed this whole bill. It really makes it a reporting requirement. It would have us doing, providing this information and posting it on our website. And so while it's not 100% perfect, it's like probably 99, almost 95% or 99% there. There's just some small tweaks that staff sort of pointed out to us. So we will work with the sponsor on this bill. What happens now is it has its bill hearing today. A HGO does a lot of work on bills in subcommittees. So this bill will go to a subcommittee for a work session. And so some of those little tweaks or little issues that we have around timeframes and what actually lawfully, what information can be made public, those things will be worked out with them at that time. But there is a similar bill that I will just mention on the Senate side, and that's being sponsored by Senator Kelly, who's the chair of Senate Finance. So it's a similar bill, much of the same sorts of things, but there are some things that that bill sort of requires more. So we'll be reaching out to her about her bill as well. House Bill 972 and Senate Bill 804. I think, Ben, do you want to discuss, or if Paul's on, maybe he could just explain it quickly to the commissioners, what the bill is about, what it does?
Let's see if Paul can turn on his
Camera?
camera and his speaker. If you
Okay.
can.
Yes,
Sorry, I put you on the spot. I'm sorry.
it's all right.
About
So,
the continuing care bill.
yes. So we have continuing care retirement communities. That's a specific type of retirement community in Maryland that has continuing care contracts with people who reside in the retirement communities. Some of those, approximately half, I would say, have nursing home beds that are part of the retirement community that were established without a certificate of need. There's a feature of current statute which allows a CCRC to have, without interference from the CON program, have a certain number of nursing home beds that they operate on their campus to, provide the continuum of care, which is the basic concept of these types of retirement communities. There's a new type of continuing care called continuing care at home, which can now be created and marketed in Maryland, although it has not actually been tested. This bill would allow those types of continuing care retirement communities that have those CON accepted, not accepted, but exceptional nursing home beds that did not go through the CON process. Those beds have limitations on who can be admitted. They're essentially nursing home beds for the exclusive use of the continuing care contract holders. This bill would simply allow contract holders who have continuing care at home contracts, rather than the traditional types of continuing care contracts, to use those nursing home beds at those types of CCRCs when that CCRC actually sells continuing care at home contracts.
Thanks, Paul.
Thanks, Paul.
Sure.
So, and then also today, actually probably as we're speaking, House Bill 1073. The cross file is Senate Bill 824. This has to do with accessibility of electronic advanced care planning documents. In parentheses, advanced directives. So this bill has gone through, this is what the combination of this bill more than likely sort of represents in a general sense the recommendations that came out of the work group that we convened at the request of the Health, Government, and Occupations Committee over the last, at the end of last session over the interim. So that work group had about a series of meetings from late summer into late fall, and made some recommendations about moving forward with regard to increasing advanced care planning. and in particular, making it electronically accessible of note. So that it is being heard in the House this afternoon. And then the Senate will hear it, I believe, on March 9th. I think it's March 9th in the Senate. So, and we were supporting that. We did have a technical amendment or a couple technical amendments that we're working with the sponsor on for the bill. And again, this bill will go to a subcommittee for a work session, and then any issues or concerns will be worked out at that time. And our expectation is that this will be this is a priority bill, and so likely it will move in both the House and the Senate. Next slide, please. Great. And then also in the past week, we've had our budget hearings, and I'm going to allow Ben to give you just a rundown on both of those hearings in the House and the Senate.
Thank you, Tracy. First of all, before I begin, I want to thank Tracy and Sade for all the work they've done, as well as Dee Stevens, who is steadfast in really keeping me on track and spotting challenges just over the horizon, as well as the senior staff who participate in a hour-long meeting once a week to talk about legislation. I was somewhat resistant to Tracy's suggestion that this would be helpful, but it's turned out to be very beneficial. I guess you can teach old dogs new tricks. But the budget hearings were, from the standpoint of MHCC, pretty uneventful. There were not significant questions directed at the Healthcare Commission. Recall that MHCC, HSCRC, and the Community Health Resources Commission have a combined budget hearing together. So, and I did share the analyst comments with the commissioners last week. I don't know if any of you have had a chance to glance at it, but the focus was really on the total cost of care model. And Katie Wunderlich, Executive Director of HSCRC, did go through some of the successes and remaining challenges with the model. And secondarily, there was a few questions on the grant programs that were are run by the Community Health Resources Commission that have been expanded recently, and really will be focusing on, in particular, health equity issues over the next several years. So there were not specific questions about the MHCC budget, which is generally, a good thing. Our CAP legislation is not directly tied to the budget, but we think that the sponsors of the CAP legislation and the chairs were waiting for MHCC to get through its budget hearings before they move on that. We hope our CAP legislation would now move relatively speedily through both bodies. Thanks, Tracy.
Oh, you're welcome. Okay, next slide, please. Thanks, Levon. So on the horizon, there are some bills that you need to be aware of that are coming up, and some of which are at this point like 2 weeks out, like March 9th. So, but I want to bring them to your attention because there are a few that are scheduled for next week. So the first bill, House Bill 906, Senate Bill 607, deals with health equity. It's a resource communities modification. So I believe this may be more of a technical bill, a cleanup bill. There was a bill that passed last year that kind of created these health equity resource communities. The the Community Health Resources Commission is tasked with setting up these resource communities and then providing grants. And so the reason why I have this on your bring this to your attention is because Chris is charged in the bill to provide technical assistance with regard to data collection and what types of data to be collected to the Community Health Resources Commission as they set up these health equity resource communities, and then decide what requirements would go into the grant and how, I guess, really to review and assess what information comes back as it relates to data in those grants. So I wanted to just sort of bring that to your attention. It did have a hearing in the Senate on Tuesday. And in the House, it will be heard on March 2nd, which is next Wednesday. And so the next bill is House Bill 1148, Senate Bill 834. This bill has a hearing in the House on March 3rd, next Thursday. And this has to do with health insurance, two-sided incentive arrangements and capitated payments. And again, I'm going to allow Ben to really explain this bill.
Thank you, Tracy. And
You're welcome.
as I mentioned earlier, I had made a mistake and had thought that this was going to be heard in the House the following week around the same date as the Senate, but we realized after the mailing went out that this is going to be heard next week. So this is a fairly comprehensive bill and represents work on the part of the carriers over the past 2 years to provide additional opportunities for them to offer value-based models in the state of Maryland. Unlike many states, Maryland has had a fairly restrictive insurance statute that limits what carriers can do in terms of both capitation and up and two-sided risk models. That is, if you do well, you get a reward. If you do poorly, you have to pay a penalty, or a payer can recoup payments. Maryland has not moved as far as many states. Some people say, well, that's odd because you have a hospital model here. And, I think that I don't want to catalog all the reasons or my suspected reasons, but, what I would say is that unlike many states until fairly recently, Maryland had a fairly unconsolidated physician physician sector in Maryland, and two-sided models were not particularly attractive to smaller practices, and oftentimes they are still not today. And that reflects the fact that CareFirst and the other payers, I think, worked pretty hard to try to assuage worries on the part of smaller providers that somehow they would be compelled to participate. So a few of the key elements in the bill, and the first is the focus of who it applies to. It applies to group practices, clinically integrated organizations, which are composites of both physicians and health systems. And that was a concept that really got a lot of traction a few years ago, but hasn't developed as aggressively as at one time was thought. But it is a type of organization that exists in Maryland. The third organization have developed our accountable care organizations, and the CMS, the Centers for Medicare and Medicaid Services, as a result of the ACA, have worked hard to establish accountable care organizations in the state. and probably would be some of the most the organizations that would be most interested in participating. Those organizations typically operate under the framework of a global budget in which they agree to be accountable for all of the care for a patient population, meet quality measures, and share with the payer in the rewards should there be savings based on a benchmark. I'm going to really emphasize a few points here, and I'm using some of the Care First summary documents because they are fairly complete in terms of what they cover, but it's not my preferred way to do this, but given the speed at which the hearing is going to come upon us, I think it's the best thing to do. I will be requesting some additional perspectives from the payer community or the provider community, which I think will largely either be taking no position or will be supporting with amendments. One of the key areas that, in addition to covering who can participate, they also spend some time defining how to protect non-participants, and carriers are prohibited from imposing penalties on non-participants. These models are characterized repeatedly in discussions with the payers as voluntary. No provider would be required to participate. It certainly goes without saying, however, that as these models progress, they are likely going to be increasingly attractive, the risk notwithstanding to providers that want to deliver value-based care going forward. But the proposal does provide protections. A second area is in areas where information is key, and when you're in a value-based program, you have requirements in order to performance, both in terms of cost and quality, and the legislation is fairly specific on what payers are required to provide to providers as they consider participating in those programs. One of the things that many times both in the primary care program and some of the non-primary care programs that CMS has offered is that the practices really didn't know in the current state what they were going to do. Was that going to be good for them or not? And this proposal does require payers to make considerable information available, so those that would be considering participation could get an assessment on whether they would benefit them to participate. And then another element is the structure of the incentive arrangements themselves, and that's of course pretty key in terms of making a determination. And it's spelled out in the types of contracts that would be required to cement the participation in these arrangements. It specifically limits the amount of loss that an entity that participates with a payer could absorb. That was a major point, and I think it still is a point of some discussion, that if you fail, the loss above the target amount, so you aren't able to generate savings, the participating provider could only be subject to a penalty of 50% of the loss above the target. So if, let's say hypothetically, if I aggregate had the target was $1,000 and I the cost to the patient population was $1,100, the practice would be responsible for 50% of that, which would be $50. Certainly having to absorb significant and significant losses are big concerns for all practices, but particularly for smaller practices who don't have the resources or financial reserves to protect themselves. And then lastly, the important point on just how much of the recoupment could be recovered relative to total payments, and that has been capped at 10%. No more than 10% of annual payments could be recouped should the practice or provider organization not participate. Once the models are in operation, there has been complaints from practices and providers. We don't get to see the data, so we don't know how we're doing, and there are requirements on how frequently the information on performance, both in terms of cost and quality, would be made available. There are protections against unilateral changes, and then lastly, there are protections against the HSCRC's rate setting authority, which is important from the standpoint of CMS, because they look on any changes that the state would make in HSCRC's ability to regulate hospital rates as an unfriendly modification for the most part. The statute also has some additional requirements on expanding the ability of payers to offer capitation, particularly as it relates to self-funded plans, which historically have not been able to take advantage of that in Maryland for some types of insurance products, and that has been expanded. The Healthcare Commission has a small but important role in this, in that beginning in 2023, we are to review these value-based programs and report back to the legislature on the impact these programs have, the number of complaints they've generated, and the overall effectiveness of the value-based arrangements. That's some language that was added at the request of some in the provider community that wanted some organization that was trusted by both providers and payers to make an independent assessment of the effectiveness of these programs. What I would recommend is that the commission send a letter of information that would generally be a favorable letter of information, because these models align very well with models that are currently in operation in the Medicare environment. There is significant benefit to having payers and providers work together on these value-based models. I want to be sure everyone understands that the models that the commercial payers will be offering won't align exactly with what Medicare is doing. But we hear oftentimes that the provider community says, the quality measures don't align, the payment formulas don't align, we can't do this. And so we know that value-based payment is the wave of the future. Providing opportunities for providers to voluntarily participate is a benefit to Maryland consumers. I think there's ample protections that are or will be placed in the statute to protect providers that are unable or not interested in participating. I think my hope is that ultimately formulas can be put in place that even small providers can join these programs. And that's why I would suggest that we send a letter of information emphasizing that these align generally with what Medicare is doing. They would be supportive of the total cost of care model, and there are flexibility and opportunities for providers that don't want to participate to continue to operating as they have been. What I will do is send out the information that CareFirst has shared with us, try to obtain information, if any, that exists from provider groups that share their perspectives, which, as I said, are generally supportive, although I don't know that they put anything together yet. And of course, share our draft communication letter of information with you all. I hope to do that over the weekend, but it may be early next week before we do this. A qualification is that in order to meet the requirements that the governor's legislative office has, put in place, is that we have to have our positions to them a full 2 days in advance, which for the Thursday hearing means we have to complete our letters by Monday if they're to submit them to them by Tuesday. So it is a bit of a challenge. I know that it's not necessarily ideal, this particular issue, and it's a big issue, but we're doing the very best we can. And I'll have more to talk about making this information available to commissioners and seeing all the letters in an organized format. Thank you, Tracy. Happy to take questions.
Great.
And is it for the primary care only or the specialist also?
So it's not specific to any specialty. It includes, it would be models devised by payers. So what I suspect is it would be primary care, possibly bundled payments, episode type payments that are offered in the Medicare environment. Some ACO, accountable care organization models, might also be considered, but there's no definitional limitation by specialty.
My suggestion will be, since hospitals and other entities are well protected by laws in Maryland, they have more incentives. Maybe have this implemented with the practices which are owned by the hospitals, because smaller practices are already struggling. It's a lot of, they will not be able to take two-sided incentive agreements. So I think majority of practices which are affiliated or partly owned by the hospitals, they will be a perfect fit for that. Patients are discharged from the hospital, they go to those specialists or primary care. It will be a good start from there. And I can tell you from my experience working with the primary cares, even myself, it's going to be a difficult sell for them to have two-sided incentive agreement. They will not be willing to do that.
And yeah, the important point, other point I would say is that, considerable time and back and forth between the MedChi and others has been that these programs are voluntary. They can't, physician groups and other healthcare professionals can't be compelled to participate. It's my hope as we move along that some of these value-based programs would be developed, which would be attractive, to smaller practices. Your concern about two-sided risk is noted, because that is a major sticking point even for large practices, and was a major area for, as I understand it, the negotiations between payers and providers up to this point.
But the unwillingness to engage in programs that don't include significant two-sided risk has been a substantial limitation for CareFirst and the payers in terms of getting adoption to the programs that exist thus far. And that's been a real challenge in the expansion of value-based care delivery. And one of the reasons the EQIP program, because it doesn't require two-sided risk, is, I believe, the ideal model moving forward, and much better than anything that's come out of any of the private sector.
Yes.
There is the oncology care model by Medicare in many states. It's not in Maryland. And that model has not actually successful, because first year there was a different arrangement. There were not two-sided incentive or risk. And as the time goes, it was more and more. Most of the practices, they dropped out of that model.
Right. I just want to point out that I said on the record that I thought that a government program was much better than anything that had come out of the private sector. Not.
We'll freeze that in time.
Duly noted and recorded.
Okay, are there any other questions about this bill? We will be talking about it again, and Ben's going to send out some additional information, which is good. The next bill, House Bill 1192, would have us do a study with regard to sickle cell disease. And actually, the study is sort of looking at, I think, insurance coverage, how it's treated in particular, like at the primary care level, and then at the emergency room level. On this commission, we've not reached out to the sponsors of the bill. We will be doing that. This is up for not next week, but the week after. I think it's a Tuesday, the 7th. So at any rate, so I just wanted to put this on now. We will have our legislative call next Thursday morning at 8. So March 3rd. So we will talk about this bill again and have a recommended position for the commissioners. House Bill 1127. This is.
Tracy, can I give a little bit input? You said it's a sickle cell at primary care level. They don't generally have these situations. Usually they are managed by the hematologist.
Hematologist. Okay.
Primary care doesn't get involved.
I think there's something about that in the bill as well. And so I'll have to look. There are varying things that they want us to look at. It's multiple things in the healthcare arena with regard to care delivery.
Thank you.
You're welcome. So the next bill, House Bill 1127, this bill has to do, this is actually a CRISP bill, and it would essentially establish them as a data utility. And Ben, if I can call on you once again, just to just explain sort of the genesis of the bill, if you will, a little bit.
Sure.
Okay.
So one of the things that I think both David Sharp and I have emphasized is, and you heard today from Kevin Hefner in particular, which, by the way, 1022 does include some roles for MHCC, but there was recognition that health information exchanges, originally conceived of as, switches that would swap information from EHRs in private practices, have over the course of the last couple of years become very important public health and care management data utilities that organize information in ways that is usable for not only clinicians, but the public health community. And this proposal would formalize CRISP role in that regard, give them some authority under Maryland law. It's important, that we make sure that it's the health information exchange, not a specific entity that is called out, because the Healthcare Commission's role in designating a health information exchange cements the public health utility authority. And I think that's important, that an entity shouldn't, by the fact that it's an entity in itself, be able to claim the data utility function. We are given authority for developing regulations on the scope of the public health information that would be shared should this pass. And what we think, we haven't taken a position on it, and we will be. We have a bit of time on that. But we do need to be sure that the consumer advocates and privacy community are fully understanding this and are comfortable with this this data sharing arrangement. It formalizes what I would argue has largely occurred. I don't see a lot more expansion of this, but it does formalize it and spell it out in Maryland law that this is something that the State Information Exchange would take on. I think one could argue that private firms could be nipping away at this functionality if it's not spelled out in state law, which we think would undermine, or I think it would undermine the health information exchange, because information exchange today has gone far, far beyond simply swapping information among trusted partners. It's the analytics and the information itself that has proven to be most valuable, and the actual data switching that was at one time thought to be the key function of an HIE has either been taken over by the interoperability requirements that are embedded in electronic health records, or will be taken over by some of the national infrastructures that have now been spawned across the country. So I think this is a key function for the state designated information exchange to consider taking on. And I think there will be some debate on it in the legislature because there'll be people with different perspectives. I suspect the privacy community will have a perspective. I think the consumers generally will have a perspective. And I think hospitals and practitioners will be generally supportive, but we'll be back in touch with you with more information on this as we gather input from those who have an interest in this particular important utility.
Okay, great. Thank you, Ben. And then the next bill is House Bill 1082. And this one actually is about health literacy information. It says Consumer Health Information Hub and requirements. And it actually there's a center at the Horowitz Center at University of Maryland would be sort of the, if you will, guardian or person or entity that would make sure that information about health or health related information is articulated in a way that it is understandable across communities. So in other words, whether it be in another language, making sure it is readable and understandable at a certain grade level, that would be something that they would do. It also establishes a fund for them. I think it's about $350,000 with regard to that. The sponsor did reach out to us as well as other interested parties, if you will, about the bill prior to the bill being drafted and introduced. So, and this will be one of the things that we'll talk about at our legislative policy meeting next week. House Bill 935, the cross-file Senate Bill 637 actually had a hearing yesterday, and I put this before you because this bill would look to expand certain behavioral health services under Medicaid, and in particular, the Medicaid home and community-based waivers. And it also expands mental health services for children and youth, certain types of services, and then would offer some sort of like reimbursement for certified peer recovery counselors. And so it has a very steep fiscal note, but behavioral health is at the forefront this legislative session when it comes to healthcare. this year. It's a lot of concern around that and accessibility for behavioral health. So because this is something that behavioral health services is something under the health plan, and then we also get data for data analysis, felt like this should be something that we should have on our radar. The next bill is House Bill 1080, Senate Bill 770. This is scheduled, the House bill is scheduled for a hearing next week, and in the Senate, March 8th. This particular bill, we did provide some background information on immigrants in Maryland, in particular those without legal status, from what we could glean. So we provided some information to the sponsor. This bill would seek to expand Medicaid services, make it comprehensive healthcare services for pregnant women and children who are who have legal immigrant status in Maryland. There is a small carve out for that right now, but it's only through a certain period, and it's only as it relates to pregnant women. So this seeks to expand that a bit. And I believe that does also have a pricey fiscal note as well. The next bill, the last bill, House Bill 1035, Senate Bill 728, would allow what they say qualified resident state subsidy program. This would allow individuals who are residents of Maryland, regardless of their legal status, to obtain healthcare coverage through the Maryland Benefit Health Exchange. So it's a pretty simple bill. And since Ben is one of the board members, the commissioners are represented on that, I felt I should bring this to your attention as well. And so I think that does it for the bills that are coming up to date, and I'm happy to answer any questions.
Additional questions for Tracy? Thank you, Tracy. That is quite a load.
Yes, I'm sorry about that.
It's okay. The state is under siege for another 45 days, and hopefully we'll make it through.
Yes, yes, we will.
All right. Next up, Ben, you're back up with a preview of what to expect in March.
So I think that we're going to be looking at largely legislation again. We have several CONs that are close, but I don't think they're going to be, given they're contested, that the time window is not sufficiently broad from here till the March meeting to allow us to bring them to the March agenda. They'll have to be pushed till April. So one of the other ideas is if we have an interest in a presenter from the provider community, from a commissioner, I'd happy to entertain that for the March meeting. I will say, however, that right now it is looking like we would try to have a hybrid meeting in March where we would meet in person if it's the commission, it's the chair's call. But given the mask mandate is gone for state buildings, and Baltimore City has waived the mask mandate beginning next week, we are starting to think that at least making plans to meet. Hopefully another surge won't intervene, and I think it would be beneficial for those commissioners who would like to do so to attend in person. We'll discuss this with the chair and let you know, in a reasonable time to make appropriate plans. The other thing is, at the start of the meeting, there are a few issues I wanted to make sure everyone knew. First off, we did send out the annual report in this month's mailing. We shared that with the Senate Budget and Tax Committee. I want to thank Teresa and Richard and Tracy and Sade and Dee Stevens for work on this document. And we used to not be able to quite make the deadlines. It's a good presentation of what we've accomplished. And if you haven't taken a look at it, please do so and let me know. Because we value most of all commissioner feedback. And lastly, a couple just sort of news items on the health technology front. As you've seen, we've are tightening a collaborative relationship with an organization called Civitas, which is the Association of Health Information Exchanges and local health improvement networks. The health improvement networks historically have been heavy users of all payer claim databases, and MHCC has historically been in both of those camps. And consequently, we're one of the few. We thought we are one of the entities that could fuel the marriage of clinical and administrative data. I did send out a notice to commissioners regarding a webinar we're having with Civitas on issues moving ahead for HIEs and health improvement networks. This is work that's done by David Sharp and his team. I want to recognize Alana for the work that she's doing there on that effort. Staying close to the health IT arena, we also were informed last week that David Horrocks, president and CEO of CRISP, has taken a position with the eHealth Exchange in New York. So a longstanding partner of MHCC will be leaving the area, and they will be on a national recruitment effort to identify a successor for David. Another key health IT partner, AI, who has been a longstanding developer for CRISP, was acquired by Point Click Care 2 weeks ago. Point Click Care is a developer of electronic health records for the nursing home industry. Kevin did not mention it, but they are a heavy collaborator. So we're just watching that as it moves forward. It does provide an opportunity to more tightly engage the nursing home community and the EHR record. Point Click Care is the predominant vendor in the nursing home arena for electronic health records. So we'll be watching that closely. And we're also watching the acquisition or the proposed acquisition of Change Healthcare by Optum Health, and a subsidiary of United Healthcare. Change Health is a key partner in some of the work that we do here in Maryland, and also a key partner with some of the payers in the development of episode-based groupers, as well as facilitating the exchange of health administrative transactions. So it's an important partner. We are watching whether FTC is going to agree to this. The timing agreement on that ends at the end of the month. So a lot of technology changes that indirectly affect the Healthcare Commission. And those are important to watch, but we're trying to stay abreast of them by being engaged with a wider range of technology partners. Thank you, Dr. Pollack.
Thank you, Ben. I just want to add my thanks to the staff for that annual report. That's a fantastic document that does a nice job of sort of outlining all the work that our staff have done over the course of the past year. encourage commissioners to take a look at it. I believe that takes us to the end of our agenda. And unless somebody has an objection, I'll entertain a motion to adjourn.
So move.
Commissioner O'Grady, second.
I think Chip Dordan had a question before we adjourn.
He does, yeah, he's got his hand up there. I don't know, is that Chip, do you have a question or does your hand just?
Can you hear me?
Yes.
Read now.
Okay, because I've had a terrible time at this end, not your fault. I had two comments. I really appreciate Ben putting the nursing home issue on the agenda today. And I think the work that was done, with the long-term planning kit and things of that nature is very impressive. I also agree completely with the annual report and how great that was. There's one major issue I've had with it though, and I went back and looked last year as well. Our leader is not mentioned, Mr. Stefan, and I don't understand, that we take the time to, and this is what a leader does. He's acknowledging his key staff and all that. But I don't see a bio, I don't see, and unless that's prohibitive, I would hope in the future that Mr. Stefan would take some credit for what he does in regards to patients and people in this state. Thank you.
Well, I would just say that, more esteemed executive directors than I also didn't have bios. I would note that Dr. Cowdery was a director of the National Institutes for Mental Health before he joined MHCC. And John Comer's has had about every job there is to have in the state. Just today was announced to be executive director or president of the Millbank Fund, but we'll consider it for the future. Maybe putting in it would be acceptable to the commissioner to put a bio in for each of the senior staff, and also a picture of the commission in the future to make personalities associated with names. That might be something we can consider. We ever
You
get back
need to be
together.
recognized, my friend. Thank you.
Thank you.
Thank you. Well, I have a motion on the table to adjourn. Do I have a second?
Second.
Second, Commissioner Boyle. Any opposed? Thank you, everyone. Have a good week, good month.
Thank you.
Thank you. Good meeting.
Thank you, everyone.